They both have AFib.
Women and heart disease, and we had a packed house and just a fabulous speaker. And we're delighted. I'm not going to go through all his credentials. I did that last year, but we are very fortunate that he does come to our annex, and so just delighted that Jim is back today to speak. I would like to do my thank yous. Thank you to the foundation who allows us to put on this lecture series. We do have a reception afterward where you can say hi to Dr. Landis. Thank you for our volunteers who help us with the reception. My wife Angela helps. Nancy Ireland, June Wright are helpers. And without further ado, we'll go ahead and get started. Dr. Jim Landis.
Well, good afternoon. We're going to discuss today something that's become really much more into the media, which I'm happy to see, actually. You'll see commercials about various medications, and it's on atrial fibrillation. And this is a topic that a lot of us have to deal with. In medicine, it is unbelievably common. And it's something that we all have to understand because it has a side of it that is quite dark. And what I mean by that is in terms of outcomes. But managed correctly, it's something that we can easily deal with and people can have overall excellent outcomes long term. What we're going to do is first go over just some basic general anatomy so you understand what this is all about. This is obviously the heart, and it's sort of a hemisection of the heart. Your upper chambers, your atriums, your lower chambers are called ventricles. Up here called the sinus node. This is your natural pacemaker of your heart. And for the most part of your life, it releases one single electrical pattern which makes its way down to the next node down here, AV node. So we go one for one. We start here, comes down here, runs down these areas that are technically muscle but have become more like electrical tissue and actually transfer an electrical impulse. The heart is, as I've always said, is a divinely guided organ, and it's an amazing thing to see. It's electrically powered. It creates its own electricity, and in doing so, it beats 100,000 times a day, a swimming pool's worth of blood per day. It starts 8 weeks in utero and runs continuously for hopefully 75 to 80 years, the most ultimate pump that's ever been created. So, I mean, right. I mean, if New Orleans had this, they wouldn't have a problem. But it really is an incredible thing. And let's face it, the fact is that if the heart stops for anywhere from 3 to 5 seconds, you're on the ground. So there's a very small tolerance in terms of what it's able to do. So it's an amazing thing. And it auto-generates electricity. The electrical patterns start in the sinus node. These are little pathways that make their way down to the AV node and over to the opposite side. And it's really just a one-for-one. Up, boom, boom, boom. This is the electrical pattern. This is what you see on an EKG. This pattern here is consistent with the contraction of the upper chambers, those atriums as we've spoken about, the big pumping chambers where the muscle becomes thick so it generates a lot of electricity, and then the recovery while the heart waits for the next beat. So once again, here's the normal heart, and as you see here, the sinus node, that's the pacemaker, sending an isolated event electrical impulse down to the AV node, which spreads through the rest of the muscle. Here's AFib. What they're trying to show you here is that it's a chaotic rhythm. You have multiple areas of the muscle generating electrical impulses. If you were to actually take a reading of the frequency of atrial fibrillation is about 600 beats per minute. But what's happening is that they're all occurring in different areas throughout the chamber, the main chamber of the heart, where they originate from, up in the right atrium and the left atrium. And it's such chaotic rhythm. Some areas are contracting, other areas positive, negative. They're all interspersed. So as a result, they tend to sort of negate each other. So what happens is that all these beats, these 600 beats that are going on a minute, about 150 of them or 160 of them make it down to the lower area and then eventually down to the heart, to the lower chambers of the heart. That's why a person who goes into AFib will usually present with a heart rate of about 150 to 160. Interestingly, the heart sort of has, in that AV node, which is back here, this AV node is very interesting in the fact that it won't allow the heart to go 1 to 1. Because obviously, if you had 600 beats per minute originate up here, sent all 600 here that came down you would go into basically cardiac arrest. So the AV node has a property called decremental conduction. It decrements down, it gears down the amount of electrical beats that strike it, which saves our life anytime somebody goes into AFib. So what they're trying to show you here is this chaotic rhythm in both atriums. A fair number, probably 150 to 160 beats, make their way down into the lower chambers. And fundamentally, these upper chambers, because there's that 600 beats going on per minute, they fundamentally negate each other to the point of where the atriums sort of stand still. Now, blood is a very odd liquid. If blood is not moving, it turns to clot. And in there lies the problem. And we're going to talk extensively about how to deal with that. So in atrial fibrillation, a take-home message is that the upper chambers are going electrically crazy. They're sending 150 to 160 beats down into the lower chambers. And fundamentally, because of that rhythm, the upper chambers are not formally contracting. It's just not a uniform contraction. They're just sort of quivering rather than squeezing appropriately. They just sort of quiver, creating the perfect venue for the development of clot, which generates the true dark side of AFib, which is stroke in human beings. Here's a rhythm strip, and this is what I showed you before, and this is called a P wave, and that's that beautiful uniform contraction of the upper chambers versus this chaotic rhythm. And actually, as I said, if you were to measure this, it comes out to about 600 beats per minute. The rich and the famous, they're not, they can't escape it as well. Both husband and wife have AFib and are very strong promoters for AFib control and dealing with it on a national basis in terms of research. Now, it's the most common rhythm that there is in the human being, and it progresses as we get older. There is no doubt. It's 0.1% if you're under 55, 1/10 of a percent of people have it. It can rise as high as 9% in those over 80 years of age. And the effect of the AFib, we alluded to just before, is threefold. Because of the quivering of those upper chambers and the lack of uniformity, the amount of blood that's actually being pushed out by the heart drops by about 25%. So it's an inefficient rhythm for the heart. That's why people very often feel fatigued. Sometimes they get overtly dizzy, and they feel poorly. In elderly, when the heart really relies on those upper chambers to sort of prime the lower pumps, sometimes people will drop their blood pressure. They could arguably go into cardiogenic shock just by going into AFib. Doesn't happen very often, but it does happen. Thrombus formation, which is the development of a clot, and embolization, fancy word for a piece of that clot taking off and just flying out of the heart, and where it goes is usually a problem. Most commonly, it goes up into the brain, causing sometimes debilitating strokes. Sometimes it makes it over the arch, the aortic arch, and goes down and clots things off. Intestinal arteries can get a cold leg. I mean, in my practice, I've seen it all. But clearly the most problematic is those of people having a stroke. Now, we sort of have classified and named AFib differently. Paroxysmal, the one on the top here, is a fancy term for on again, off again, comes and goes. You're in a normal rhythm, then you're not. Then you're in, out, in, out. Persistent is where a person remains in it, but can be converted out of it with an electrical shock on the chest. You can go after it, you can do ablations, there are certain things that you can do to ultimately get rid of it, and it will stay out. Permanent is as the name would imply. It's permanent. Nothing you do, everything you try, medically or mechanically, will not allow it to go back into a normal rhythm. Recurrent AFib is where it just, once again, sort of comes and goes, but on a less frequent basis. And then lone AFib. Lone AFib is sort of interesting, and this is, sometimes we see this in very, very young people, people who are 20, 30 years old. It's more of a congenital-based issue. And interestingly, those people, despite the fact that the physiology of what's going on is the same, the chambers are, once again, doing exactly what they would do in somebody who's 60, 65 years of age. Interestingly, they don't seem to have a problem with stroke, and Coumadin isn't even recommended. So I've always found that to be an interesting situation. But nevertheless, that's the way it is. Causes of AFib. Coronary artery disease at the top of the list. The heart sometimes becomes electrically irritable when it doesn't get quite the amount of blood supply that it should. So when somebody presents with AFib for the first time, one must also be concerned, do they have blocked arteries causing this? Hence the need for stress testing and evaluation at the time. High blood pressure by itself can cause this. Significant valve disease, especially of the mitral valve. The reason being is that the mitral valve leaks. It will leak backwards and expand those upper chambers, the left atrium, from blood overload. And if you stretch those upper chambers that I showed you on the first pictures, if we stretch them because of fluid overload, high blood pressure, valve problems, once they stretch, those fibers that I showed you, once again on those very first pictures, get stretched and tends to promote the development of AFib. People with congestive heart failure, once again because of an overloaded fluid within the system. Heavy drinking, alcohol. Alcohol is a toxin to the heart. I hate to tell you this, but it is, okay? And it does not distinguish between beer, wine, or it really doesn't. It doesn't, the heart doesn't say, oh, well, this is a, 67 Merlot. I'm not going to go into AFib. It's just going to happen. Alcohol is alcohol is alcohol in any way, shape, or form. It's just a concentrational and volume difference. So beware. Severe body stress, sepsis, people who become overtly septic. Sleep apnea. This is a sleeper, as you could say. I mean, it is more and more we know about sleep apnea, where people stop breathing and drop saturation levels. And it is a major cause, and it's becoming more and more evident in the literature as a cause for these upper chamber dysrhythmias. As far as long-term treatment of AFib, very often, without a doubt, it will be a failure if the sleep apnea is not addressed. Chocolate or thiobromine, caffeine, these are all classified as sympathomimetics and can drive people into this rhythm. Genetics, as we've talked about, whereas sometimes people practically are born with it. Not quite, but it occurs early in life, in their early teens and 20s. Hyperthyroidism, where the thyroid is overactive. Once again, a hypermetabolic state driving the heart, and then obviously increased age. As far as evaluating people when they come in, as we had mentioned, stress testing, we have to check the thyroid and make sure the thyroid's not in trouble. We check the chest x-ray, make sure that there's nothing going on within the lungs themselves, showing signs of lung disease. Ultrasound of the heart to check those valves that we mentioned, as well as the overall function to rule out the possibility of congestive heart failure. And just a good old EKG to evaluate the heart in general. As far as managing AFib, at the top of the list, thromboprophylaxis, fancy word for stroke prevention. And we're going to talk quite a bit about that. Rate control. When a person presents, as I said, they usually present with a rate of 150, 160 beats per minute. So they come in, They say, boy, my heart's like pounding out of my chest. So they present to the emergency room very often or to their doctor's office, and the first thing that we usually do is we start medications to help slow them down, Drugs such as beta blockers, calcium channel blockers, very often in combination with a drug called digoxin. It's these drugs, either individually or in combination, will slow the heart rate down. And then we immediately have to prepare these patients to be placed on a blood thinner of and there's various types of those. Those who come in really in distress, obviously they're admitted to the hospital. We give them those medications intravenously so that they work very quickly. And then on top of that, we put them on heparin, which is virtually within a few minutes of being started, instantaneous blood thinning to prevent further clot formation. Now, you don't know that there's clot in there, but you must assume, if we're going to make a mistake, as I always say, we're going to err to the side of safety. We always have to assume that there may be clot in those upper chambers, as we discussed initially. You just never know. And people really don't know when they went into it. Studies have shown this in terms of awareness of when people think they're in and out of AFib. They really don't know. Sometimes their heart rates will be in the 110s, 120s, they don't feel it, but once they hit 150, 160, they will. Meanwhile, they were in it, and we get concerned. Anything over 48 hours, a person who's in AFib for more than 48 hours, you must assume that they have clot sitting in those upper chambers. Sometimes a person's in the hospital, they're in a normal rhythm, and they'll go into it, and then we have that luxury within the first 24 to 48 hours of either giving them medicines to try to convert the rhythm or actually give them an electrical shock to bring the heart back into a normal rhythm. But the far majority of situations are that people are just out and about, doing their daily thing, and all of a sudden they wake up in AFib. Sometimes it wakes them up. Sometimes they don't know. Sometimes they just present to their family doctor's office, and they do an EKG, and lo and behold, they are. Rhythm control. Rhythm control is where we actually try to use medications to change the rhythm back to a normal rhythm. What you have to remember is that there are basically two approaches. There are two lists of medicines. The medicines you're most commonly heard of is beta blockers, calcium channel blockers, and digoxin, as I just said. Those are the three that help control rate. They do not have the chemical ability to change the rhythm back to a normal rhythm. Now, sometimes once you get the rate down, people will convert, but that's on their own. There is a whole other series of medications that are made and have the chemical ability and the medical ability to be able to change the rhythm back to a normal rhythm. Drugs such as amiodarone, sotalol, these are all drugs, Multac, these are all drugs that are made and have the ability to convert a rhythm from a good rhythm, from a bad rhythm, back into the normal rhythm. Now, once again, if a person presents an AFib and we don't know how long they've been in it, would we want to start those medications to change their rate back to normal? No, because we're concerned that the clot that potentially has been generated in the upper chambers, you start those chambers to start squeezing, you don't give the body a chance to dissolve that clot being put on blood thinners, and as a result, you can promote people having a stroke. So we have to be very careful how we do this. After we go through that period of time of waiting, which is usually 4 to 6 weeks, or sometimes we actually can use a special ultrasound of the heart and check for clot in those chambers. Once that's been done, then at that point, we can try to actually, if a person's still in AFib, put them to sleep for a few seconds, give an electrical jolt across the chest, and 85% of the time, we will convert the rhythm back to a normal rhythm. We call that a cardioversion. But its long-lasting effects are variable. I found an interesting statistic being that they looked at this, and the sole factor in terms of looking at the success rate was predicated on one's age. And they looked at people who were under 70 and over 70. And what's interesting is that a person who is 70 years or older, even if they have initially a successful cardioversion back to a normal rhythm, the chances of them remaining out of AFib permanently is 12%. 88% chance that at some time, be it the next day or maybe a year from then, they will ultimately return into an atrial fibrillatory rhythm. And as far as the need for hospitalization, that depends on how the patient presents. So why thromboprophylaxis? And we're going to, this is the major thrust of this talk, is the concern obviously about stroke. It's obviously devastating. Sometimes people's herald event, the way they present, is that they wake up in the morning and they can't move the right side of their body. They stroked while they slept. They were in AFib. They didn't know it. They had a stroke when they slept, and their life has changed forever. So this is the major thrust of what we try to prevent in AFib. Now, every 40 seconds, an American has a stroke. And as we had said before, if you look at AFib, it's an age-related phenomenon. And you have 1.5% between 50 to 60 years of age, and you can, by the time you're 80 to 89 years of age, you can have a stroke rate of almost 25%, basically. You round it off at 25% if not treated appropriately, if in AFib. So the older you get, the more likely you are to have a stroke in that rhythm if you're not put on the appropriate medications in a timely fashion. Now, we have this way of sort of grading people, and this is sort of important. People who have CHF, hypertension, age greater than 75, diabetes, or have had a stroke, we assign a point value. And we call this a CHAD score. It's sort of convenient. And here's the CHAD score. From 0, your chances of having a stroke is 1.9% if you're in AFib. Okay? If you're in AFib. Now, a person in a normal rhythm, a perfectly normal rhythm, as I showed you initially, can they have a stroke from the heart? Yes. 0.8%. It's a little less than 1%. So this is a little bit more than two times with a CHAD score of 0, meaning that you had none of those factors that we just pointed out. The big cutoff is right here, a CHAD score of 2. Once a person has had a CHAD score of 2, let's say they're over 75 and they have hypertension, very common combination. They have a CHAD score of 2, that means they've got a 4% chance of having a stroke if, in fact, they're not treated appropriately in terms of blood thinners. And then, as you can see, if you have a CHAD score of 6, up to 18% chance. Okay, so now we're talking about the thrombo. Well, how do you prevent it? Now, you've all heard of, well, I take aspirin. Oh, I take aspirin and Plavix. Oh, I take Pradaxa. I take Coumadin. Okay? We're going to talk about some of this because this is important. As far as aspirin is concerned, some people refuse to deal with testing for Coumadin. They just don't want to deal with it. It's not a good idea. You will reduce your chances of stroke by 20%, but it's still far inferior to almost anything else. If you draw the line here at the 0 mark, aspirin being better, all the studies, for the most part, are to the left of the line, if you can create that imaginary line here. But the fact is that we have medications that are a lot better than that. When we say vitamin K antagonist, that's a fancy way of saying Coumadin or warfarin. And it antagonizes vitamin K in your system, so that's why they've called it this. And there you've got a 60% reduction. So Coumadin is about 3 times better than aspirin alone. And as you can see, once again, here's the 0, and all the studies, these are all studies that have, all the trials have shown, they're far to the left, showing that warfarin is better. There's never been a study that's really shown that warfarin is worse or equal to doing nothing. Every single trial there is has shown a benefit of warfarin or Coumadin. This is a study that shows Coumadin versus aspirin. And if you look at the 0 here, once again, warfarin is better. There's this one study, okay, it's an isolated study. But clearly, the majority of these other studies, especially SPAF2, which is 100,000 patients, I mean, the number of patients that were involved in these studies is tremendous. There's really very little doubt. Once again, Coumadin is better. Now, clopidogrel, that's the fancy term for Plavix. And this was looked at in what we call the active trial. And these trials looked at and said, you know, how about Plavix? It's easy to take. You take 1 pill a day, no testing. It's a breeze. And it showed that, especially when combined with aspirin, aspirin and Plavix together are better than aspirin alone, but still, Active W, the Active W trial, showed that warfarin still wins. It's still better. So the most effective is Coumadin. The least effective is aspirin, and aspirin and Plavix are sort of in between. The interesting thing is that on a subset of patients from the Active W trial, it showed that both when you're on aspirin and Plavix, although you stroke less with that combination, you have, that aspirin alone, you have an increase in intracerebral bleed when people do have spontaneous bleeds. So it's a trade-off. So how about the combination of all three, aspirin, clopidogrel, and warfarin? Well, sometimes we find ourselves in that position. People have mechanical valves. They definitely need the warfarin. They also have had a stent, so they need aspirin and Plavix, combination of problems. And in that scenario, you can have people on all three. Very often your pharmacists freak out when they see that you're on all three and say, you can't be on that. Well, yes, you can. But obviously with great trepidation, and we have to be extremely careful. And if you're going to drop one of the three, aspirin's the one to go. That's what's recommended. If a person starts bruising excessively, you got to keep the Coumadin, you got to keep the Plavix. You can lose the aspirin. Warfarin, or Coumadin. As you know, briefly, you've heard about this. It's been around forever. Yes, it is rat poison. We've all heard that. But the fact is, this drug has been around forever. The INR stands for International Normalized Ratio. This sort of just unifies the measuring ability so that if you were to, let's say, be on Coumadin here and have a test here in the United States and then go travel to Europe and need to be tested there, the differences in the reagents used is nullified by the use of this mathematical ratio. And we want to keep you between 2.5 is great, and in the range basically 2 to 3 for AFib. That's what the goal is. It's difficult from the standpoint that you have to be tested. It requires the drawing of blood, either a central draw from your arm or at a minimum a finger stick. It causes, it adjusts your diet, green vegetables, things like that have to be consistent. They don't have to be eliminated, they just have to be consistent in your diet because they contain vitamin K. So vitamin K containing foods need to be held at a constant in your diet so that we can work the dosing of the Coumadin around you. They don't have to be eliminated. People say, well, I love salads, I can't have salad anymore. That's not the case. You just have to you can't be meat and potatoes for 3 weeks and then salads the rest of the time. It's got to be steady. What's interesting is that in terms of monitoring, self-management, where you actually get a small device, you stick your own finger, you do the test, and then you call into a center such as, for instance, in my practice, we have people designated just for this, to your family doctor, and they help you with the adjustments. But the frequency of testing improves the overall outcome of compliance, 72%. Anticoagulation clinics where you actually go to a designated place for AFib, about 66%. And then your community physicians, and what I mean by community physicians is anybody, the physician, like cardiologist, anybody, any guy in private practice where people just sort of roll in and roll out, doesn't help. You need a formal clinic, and you need people, ideally, if they can do it, to test. Similar to diabetes. All the data showed the same thing, that once home testing and self-testing of the diabetic do's and don'ts improved dramatically. Same thing with this. But a hassle nonetheless, there's no doubt. Like any other blood thinner, you got to be concerned about, obviously, overdosage or underdosage with Coumadin. If you're too low, If your INR falls, we said between 2 and 3. If your INR falls below 2, you might as well be taking Pez candy. It doesn't really help. It's no better than placebo. If you go too high, obviously people can start to hemorrhage. And obviously that's an issue. You have about a 1% chance of a major bleed per year and about 10% chance of minor bleeding and injury. People bump into things, twist an ankle, things like that, fall off a ladder. So these are the things you've got to be careful of when you're on a blood thinner of any type. We talked about this. You got to just have consistency in your diet of vitamin K containing foods. As far as warfarin, it has to be held sometimes before surgery. We stratify people into high risk and low risk. A person who's an AFib, who doesn't have a mechanical valve, who has never had a stroke, who has never had a clot go to their lung, these people, you can stop the Coumadin 4 to 5 days, let the body metabolize it, it wears off, you go for your surgery. Once the surgeon says it's okay, you start taking the Coumadin again, and you just sort of glide back up to your normal rate. The other groups that I mentioned, those people who have had valve surgery, clots go to their lungs. These people, or anybody who's had a stroke because of AFib, they are high-risk AFib patients. And those people require bridging. They require to be bridged, meaning that we give them like little injections of heparin in the belly and keep their blood thinned out right up until 12 hours before the procedure, so that you let the Coumadin wear off, but you sort of pick up the tab with little injections of heparin. Lovenox is the drug that a lot of people use, and that protects you, as does the Coumadin, as the Coumadin did, right up to the point of surgery. And then it would be restarted the minute the surgeon felt comfortable with that, and then you're bridged with that. So it creates a bridge, a tie-over, if you will, from the Coumadin, so that you're not exposed to the possibilities of forming clot less and less. The challenging situations for warfarin, well, obviously, if a person's unsteady on their feet and they have an increase in falls, people with significant gastrointestinal bleeds, urinary tract bleeding we could add to this list. Obviously, anything that causes bleeding is polar opposite of what is the polar opposite of what we're concerned about in the face of being on a blood thinner. They're always at increased risk. And at times, we are in a situation where if we see somebody and they've had 3 or 4 falls, they've had a broken hip from a fall, you start weighing the good from the bad and say, you know what, this person would be better on aspirin or aspirin and Plavix than being put on Coumadin. That's a judgment call. That's where you are counting on your doctor's judgment. The other interesting thing is that if you have a person who, despite all attempts, if you cannot get a person's INR, their blood thinning level with a Coumadin, to be therapeutic at least 6 out of 10 times, statistically you are better off on aspirin and Plavix. So you have to have about a 60% rate of success in INR management, or else you're better just taking 2 pills a day and calling it a day. Now, some of the newer agents, Xarelto, okay, and dabigatran, which is Pradaxa. We've heard a lot about these drugs, and they sound sexy to everybody. They're all over the TV, especially Pradaxa. This is the one that we're going to zero in on. Xarelto has been released and is being used. Interestingly, this drug has now, just as of a week ago, had extended use now for people who have thrown clots to the lung, as well as people who have developed clots in the lower extremity. Initially, it was only approved for AFib, but now this drug Xarelto is out there. Pradaxa, you see it on TV all the time, and they talk about AFib, and you have a chance of a stroke 5 to 6 times out of an average individual, and that's all true. And what's really nice about Pradaxa is that you just take it. It's a pill. You take it twice a day, you're done. It's great. There's no testing. Sounds great. But there's no free lunch, all right? As everything in life, there is no free lunch. What's the payback? Well, the payback is that Pradaxa is a great drug, and it actually statistically has shown better outcomes in terms of having strokes than Coumadin. The reason why is that Pradaxa holds a steady level. You never get the dips, the peaks and the troughs. It's just up, holds its level. Whereas people on Coumadin very often will slip below that level of 2, and they'll be exposed to a possible stroke. If, however, you were to be able to wave a magic wand over somebody, put them on Coumadin, and say your level will be 2.5 forever, then they're equal in terms of their overall effect. Now, here's the no-free lunch part. Pradaxa is not able to be reversed by any agent that we have anywhere. Meaning that if you're on Pradaxa and you, God forbid, have an upper GI bleed, you develop an ulcer, and you develop a significant bleed, you rush to the emergency room, you're vomiting blood, there is nothing they can give you to reverse that. You have to wait for this drug to wear off, anywhere from 12 to 14 hours, as much as 24 hours in some. So, whereas with Coumadin, it's fully reversible. We can give you a drug called, we can give you an infusion of what we call fresh frozen plasma, which are the clotting factors that Coumadin affects in your body. We infuse that into you, plus vitamin K intravenously. And within a very short period of time, we can bring your clotting right back to normal. For either of these two drugs, there is no way to reverse it, other than, if you want to get really technical, dialysis. It is dialyzable, meaning that if a person was to put in a catheter very quickly and do hemodialysis on you, we could get rid of most of it. It's probably the last thing you want to do in somebody who presents with a low blood pressure, possibly what we call hypovolemic shock. They couldn't tolerate being put on the Maytag. It's just not going to happen. So it's really a situation that one has to be cautious of. We've seen an increase in risk of stroke, increased risk in bleed rather, over the age of 75 with both these drugs. So that automatically, it's not that it's contraindicated, but 75 is really the magic time in terms of when these drugs start to run into more problems with bleeding. This is everything that I just said to you. Okay, last portion of the talk, AFib ablation. So we talked about that if you're in AFib, you have the option of being put on a blood thinner and a drug to control one's rate and just live your life. And those drugs, the blood thinners, were the ones we discussed, and the use of medications to do nothing but to slow you down. Option number 2 is that you put on blood thinners, and we give you drugs to try to convert the rhythm back to a normal rhythm and hopefully have the rhythm stay. Although there is no drug that really is anything more than 50% effective. Multac is about 40%. You have amiodarone at the top of the list. Sotalol, these are all drugs you may have heard of. These are all drugs that help convert the rhythm and keep you in a normal rhythm. But none of them are better than a 50-50 shot on a long-term basis. The last option is come into vogue, and it is something that is very intriguing and is only going to get better with time, as it has currently, which is atrial fibrillatory ablation. And what this is a mechanical procedure of where we put wires from all various veins into the heart, cross over the heart. We now know that AFib, the little electrical circuit problems, live very often around on the left side of the heart, where the veins drain from the lungs. After the lungs oxygenate your blood, the heart swings blood up to the lungs, brings it back down to itself on the left side, from the right to the left side, and where these veins drain, right here. So this is the right side. This picks up all your blood, gets pushed up to the lungs, let's say up here, and then then they swing back, and these are the 4 openings of the pulmonary veins. And what we do is we put wires up, we find out where they are, and then with ultrasound, high-frequency ultrasound, we actually create little burns That's what this white line is. And we sort of surround these areas. It's called pulmonary vein isolation. By creating these little burns, you actually create scar tissue. That scar tissue migrates into the muscle and disrupts these little short circuits that you have. And you get rid of the AFib. Now, the overall success is depending on what kind you are. If you're what we call a paroxysmal, meaning that you go in and out of AFib, first-time success rate is probably 75 to 80% on a first attempt. Sometimes you need what we call a touch-up, where you go back and have extensions of these. We don't do it all at the first time because it's too much for the heart, but then we can extend these. And then at that point, you're looking somewhere 90%. If you're a persistent, meaning that the AFib is just steady state, obviously the heart being sicker because it's in it all the time, the success rate is lower. It's in the 65 to 70% range. And it also depends on all those other confounding issues. You know, how big are the chambers of the heart, high blood pressure, all these different things. Do you have sleep apnea? Sleep apnea really lowers the success rate of this, unless it's treated, obviously. So this is a mechanical way. Now, the Mantra 2 trial just came out about a week ago, which was very interesting, and it compared mechanical with medical management, using drugs that help keep you in a normal rhythm versus this. And for the first 2 years, there was no statistical difference. Beyond 2 years, there was a major statistical difference and better outcomes for those who undergo ablation. So the long-term benefits are there. Initially, you're just as good as medicine for the first 2 years. But later on, you have many more people that go into, that stay out of AFib permanently. Going back to that CHAD score, you know, when people look at this and they say, hey, that's great, you know, I'll just go, I'll get this done, I'll have this done, and I'll be free, and I can stop my blood thinners, and I can stop all those crazy medicines that make me feel sluggish. We'll just get this done. The fact is that even if your CHAD, the interesting thing is, and it's still being looked at, but the recommendation currently is that if your CHAD score, that scoring system that I showed you, is 2 or above, even if the AFib is ablated successfully, you sit at a higher rate of it undoing itself despite an initial success rate. So they recommend to continue the blood thinners. But all the medicines that would be used to either keep you out of it or slow you down, those can be eliminated. But the real hassle medicine, the real one that you really want to get rid of, is the blood thinner, let's face it. And the recommendation currently is that if your CHAD score, so let's say you're 75, you have high blood pressure, even if it's managed, but you have high blood pressure, you're 75 years of age, you undergo a successful ablation, you have a CHAD score of 2, you need to remain on Coumadin, or the blood thinner of your choice at that point. So that takes a little bit of the edge off of it. However, there are studies that are going to be looking at this. You know, the counter argument is, well, if somebody walks into my office and they're 75 and they have hypertension, do I start them on Coumadin? So either you believe in your ablation or you don't. If you trust the ablation outcome, then why would somebody, just by the virtual fact of being 75 and having high blood pressure, of which so many do, why would you need to be kept on a blood thinner? But I think the reason is that, once again, in medicine, we err to the side of safety. And I think at this point in time, I think ablations will be getting better and better, and maybe they'll do away with that recommendation. But as it stands now, there's still enough people that flip back into AFib, irrespective of an initial success, that it's not worth stopping the drug that would prevent the catastrophic, true dark side of AFib, which is stroke. Okay, well, thank you very much. Are there any questions? Platelets, the answer to that is no. It creates a permanent bond, but you can give fresh platelets to people. But for the most part, Plavix takes anywhere from 5 to 7 days to wear off. Now, interesting, There is a test now that we do. It's called a P2Y12. P2Y12 is a way, it's almost like an INR for the Coumadin. This test called a P2Y12 can show you Plavix activity. And we're starting to use it at Venice all the time because the recommendation by the American College is, boy, I feel better coming out from under that. I was wondering what, it's like I don't have a lot up there. At Venice, we're doing this, and it's not being done in a lot of hospitals. And what's so wonderful about this is that the recommendation by the American College of Cardiology and the American Heart Association was an automatic 5-day wait before any kind of surgery. So sometimes I get people with critical coronary artery disease who really need a triple bypass like yesterday, and then we got to sit there because they're on Plavix and twiddle our thumbs because the use of blood products if you just head right into surgery is huge. So now what we're doing is we're doing P2Y12 levels, and that shows basically how much Plavix you have in your system. And what's very interesting is we're starting to see very often we can bring patients sometimes 2 days, 3 days, where we would have been waiting at least another 2 or 3 days by the good old general rule. But now we have objective evidence to measure Plavix activity. And it's not quite as long as we thought. Once again, we went to the side of safety and made it 5 days. We've not had anybody that we've measured P2Y12 that have really had to wait the 5 days. It metabolizes out faster than we thought. And we are successfully now sometimes taking people to surgery, open heart surgery, the most aggressive surgery being performed in the world today. We're taking people to surgery day 2, day 3, and having no bleeding problems afterwards. There was a question back there, I believe. Yes, sir. 0.8%. 0.8. Mm-hmm. Oh yes, both Xarelto and Pradaxa lower stroke rates, and statistically, when they go head-to-head against Coumadin, they are better than Coumadin because there's no fluctuation in their levels as there is with Coumadin. So for pure stroke prevention, they do great. And if you sort of like a horse with blinders and look only at that, that's the way to go. And they're easy. But once again, the dark side is they're irreversible, and if you have any bleeding tendencies, then that becomes a little bit more of an issue. I just want to get back to this gentleman's question for a second about the stroke risk at 75. That's from a clot from the heart. You can have strokes from any number of causes. Specifically, if what we're talking here about embolic stroke, meaning a clot flying up from the heart into the brain. In that, you're at 0.8. Yes, ma'am.
I would just like to say, the clinic saved my life. 3 weeks ago, I went into the clinic for something, and the next thing I knew, I was in an ambulance. The next thing I knew, I was up in Venice, and you used to take care of me, Dr. Beltran. And
I'll have to speak to him about that.
and
He's been my buddy for 30 years.
every 3 or 4 days with my blood at the clinic, and they fax it up to Dr. Beltran. But I just do want to say that between the clinic and between you just saved my life. But I have one bad question. I'm on Coumadin. I'm starting to lose my hair. So could you please tell me
Huh.
how I can get it? Yes. That's one of the side effects.
It is, but it's also a side effect of some of the, are you on beta blockers also? Are you on like Lopressor, or, there are other drugs that can cause that. Okay, we'll take care, we'll look into that then. Okay, I guess you know what, we'll probably head over to, yes, sir, you've been raising your hand.
Ablation convert the AFib to AFib. Is that a stage wherein it
Great question.
results in no AFib?
Excellent question. What we didn't talk about, we're talking about AFib today, but there is a sort of an intermediary rhythm between a normal rhythm and AFib, and that's called A flutter, which is a little bit more of an organized rhythm.